So likely many of you can relate to the picture that you're seeing on this introductory slide here, where you're probably often feeling like you're drowning in paperwork. There's just not enough hours in the day to get everything done. And the last thing you need right now is more paperwork on top of everything else. So we here at ANBLPN certainly do acknowledge that. Nursing professionals already have one of the hardest jobs in the world, and the pandemic and the staffing shortages have made that job even harder. But at the same time, we also have to acknowledge the importance of our documentation and understand that our documentation is really a vital piece of client care that we have to be adhering to as licensed regulated professionals. And over the last, 2 years or so, documentation has really become a struggle for nursing professionals, and we've received some increased concerns and complaints in that regard. We have revised our documentation guideline. If you've not seen that, we certainly welcome you to take a look at that. We just released the revision in February of this year. So you can find that on our website under practice resources. And we also created a short little FAQ for documentation that we of course welcome you all to review. That will coincide well with this presentation. So today's presentation is going to focus on why we document, when we document, and what can happen if we fall short on our documentation. And I'm going to share with you some real life examples of nursing professionals whose inadequate documentation led to some issues with professional misconduct. So documentation, we know, is a required nursing action that provides the foundation for information on the status of the client's healthcare needs and the services that have been given to that client. It's an integral part of that safe, compassionate, competent, and ethical care that we provide to our clients, and it is not optional. So we're often asked, well, what do we document? Well, just to give you a couple of examples, we are, of course, required to document all aspects of the nursing process. So that's, of course, our assessment, our planning, interventions that we perform, and evaluations. Any kind of communication that we have with physicians or nurse practitioners or anybody else on the healthcare team, and that includes their name, which we're going to chat about more shortly. Any relevant comments made by our clients or their family members, any information related to medication administration. And this is an area where we see the biggest amount of omissions is people forgetting to sign for their medications. And of course, any non-compliant or risk-taking behavior by our clients. So, if client incidents like falls or illness, just to kind of name a few, those of course have to be documented. So nursing, we always say, and it's true, of course, is that it's a self-regulated profession, which means that both RNs and LPNs are responsible for what they do, and we're responsible for what we don't do. So that means that we're accountable for our own actions and inactions. So therefore, we chart our own actions because our practice is our responsibility. And that responsibility includes doing our own documentation in a timely and accurate way. And it might be true for some people who have been working as an LPN for several years. Maybe in the past you weren't expected to do all of this charting in your practice environment, and maybe the RN mostly handled that part of the job in the past. But that's certainly not the way things are anymore, and that of course would not be considered best practice. We are the only ones who can be responsible for the care that we're giving, and so therefore we should never be charting on behalf of anybody else, because that would go against our documentation standards. And I also like to make the point to please refrain from writing things like RN made aware. Somewhere along the lines, we got into this habit of adding this at the end of our charting, like it's just this little bit of sprinkle or glitter that we use to sum things up nicely. It really doesn't add anything to your entry, and it almost acts like you're putting the onus on the RN and saying, well, I'm done now because I told the RN. So if that's a habit of yours, it really is time to break that habit. So I throw this question out to you now, knowing what the answer is going to be ahead of time. So I'm just going to launch a poll to you now. If you could just take a moment and answer the poll question that's going to appear on your screen. So you should be seeing that now. So do you feel that documentation interferes with the time that you could be spending doing hands-on client care? And of course, your responses are always anonymous. I'm not going to see anybody's name, so please just answer honestly. It'll just come up as a percentage. I'll just give you a few seconds to answer that. Everybody's busily doing that. Thank you for participating. So I'll give you about 5 more seconds if you haven't answered already. Okay, so almost everyone has voted, so I'm just going to share those results with you. So as you can say, about 61% of you feel yes, it does interfere, and about 39% of you say no. So that's not surprising to me at all. Most people do feel that it's interfering with the direct hands-on client care. So I'll just take that down. 1 second. So it's no big secret, obviously, that every single one of you are putting in extremely crazy days due to the pandemic, those critical staffing shortages that we're experiencing. We've got increased acuity of care. And because of this, it often is our documentation that gets abandoned as we're trying to care for the needs of our clients. However, it is when you are at your busiest that you need your documentation the most, because it is our main communication tool. And that's really important to understand. We all have to understand that our documentation is as equally professionally and legally valuable as our direct care is. It's really essential for those positive client outcomes, and it is a key component of meeting our standards of practice. So documenting not only puts your clients at risk, so that old adage of if it wasn't charted, it wasn't done, but it also puts our own accountability at risk, because if the care you gave is ever going to be questioned later on down the line, it is going to be your documentation that's either going to save you or hang you. So since the pandemic and the, of course, increase in staffing shortages, I am often asked by LPNs, well, what can I do to protect my practice? The best way you can protect your practice is through accurate and timely documentation. So the Canadian Nurses Protective Society have stated that entries you make at the end of a busy shift might not hold the same weight as frequent entries made throughout the shift in the court of law. So that just really further emphasizes the importance of completing your documentation in a timely manner. So why do we have to document? Well, to put it simply, your documentation is not optional. It needs to be viewed as that critical aspect of care and not as taking away from client care. So our documentation, it's definitely required by law, and it is clearly stated in our standards of practice that we as nursing professionals have to be adhering to. And there's also a lot of positive impacts of our documentation. So it certainly demonstrates that nursing professionals have applied their nursing knowledge, they've used their skill and their judgment, and that they're acting on that knowledge and evaluating the outcomes. It provides that means of communication with the rest of the healthcare team. So it's a key ingredient for us to ensure that continuity of care. Data from our medical records can also be used in approved health research or quality improvement projects, so that's always a positive. And our nursing notes can also be used as evidence in legal proceedings. So when regulatory bodies do receive an official complaint about a nursing professional's practice and that LPN gets investigated, the documentation is going to be used as a key piece of evidence. So our documentation needs to be done, and it needs to be done well. So the most important purpose of our documentation is, of course, to communicate health information. So we have to be communicating this information to other members of the team to ensure consistency and that continuity of client care. It's going to communicate to your team what your assessments were, the planning, the implementation, and the evaluation of the care provided, and what the client's response to that care was. And it's also going to serve to communicate what the client's preferences are, or maybe their express needs. So it's a vital part of client care and patient safety, and we really have to remember this because our documentation is not just paperwork, it is part of our client care. So LPN practice is of course legislated in the LPN Act, just as an RN's practice would be legislated by the Nurses Act. So documentation is part of our standards of practice. So if you're not documenting, then you are in direct violation of your standards of practice. So if we look at our LPN standards, which of course we have the newer version now, the 2020 version, and we look at the first standard one about professional accountability and responsibility, it does state that LPNs are accountable and responsible for their own practice, conduct, and ethical decision making, and that LPNs document and report according to established legislation, regulations, laws, and employer policies. So you see it is clearly written in our standards, and as regulated health professionals, we always have to be adhering to our standards of practice because that's the minimum expectation of all LPNs. So that accountability really means that we're being responsible for our actions and the consequences of our inactions. And documentation really demonstrates your responsibility and determines whether you have been accountable to your clients and to your employer. So it really answers the question of who did what and when. So LPNs are responsible for recording that information in a timely manner. So we really need to be aiming to document information as soon as possible after the care is provided, because that's what enhances our accuracy and the credibility of the chart. And I know that a lot of you are probably thinking right now, well, they don't know what it's like. They just sit behind a desk all day, or, in a perfect world, I would chart right after I gave the care, but who the heck has the time for that? And I want you to know that we absolutely, completely understand that this is a huge challenge right now. And I'm not by any means saying that this is easy, but we're just sharing this information with you so that you can hopefully avoid any bad situations in the future. And if I can just share a quick story with you, anyone joining this call right now, if you're having issues with documentation, you're certainly not alone in this being an issue or a challenge. I have definitely been pulled into work environments at the requests of boards of directors because the charting was so severely lacking that it's amounted in different things like, hundreds of medications not being signed for in the run of a year. And you absolutely heard me correct when I say hundreds. So if we don't pull up our socks with our charting, that is how bad things can get. So even though you are all facing multiple barriers, it's really important that you still understand the importance of your charting. So that brings me to the legal aspects of charting. And of course, we at the regulatory body, we don't give legal advice, but you should be aware of your professional responsibilities in relation to your documentation. So in plain terms, ignorance of a standard or a policy is not a defense. We can never just say, well, I didn't know. Excuse me, you need to ensure that you are aware of your standards and whatever your workplace policies are regarding documentation, because that is part of your personal accountability. So your documentation, as it says on the screen, it is the single most important piece of evidence that is used to support your practice. That timely charting is going to protect you, and a lack of charting is what can harm you. So if part of your care does come into question and it's an event that happened, 10 or more years ago, chances are that where your memory might fail you, your charting is going to save you and back you up if it is done well. So the Supreme Court of Canada actually addressed this a few years ago in a case where a client had undergone a spinal infusion and they were returned to the post-op unit, and then the very next morning they were found dead. So the chart showed that there was no nursing entries from 2200 to 0500 when the death was first discovered. And because there was a lack of charting that was done on this patient, the court determined that nothing was charted because nothing was done. And you perhaps could argue that until you're blue in the face, but at the end of the day, there was nothing there to support claims that they had been caring for that client throughout the night. So whenever a client or a family member of a client initiates those legal proceedings, the courts are going to rely on your nursing documentation as evidence of the care that was provided to them. And most court cases aren't started until several years after the fact. So the client's chart is often the only reliable source of evidence that's going to be used in those proceedings. So as I mentioned, we did release our revised practice guideline on documentation in February of this year. So I just wanted to share with you a couple of tips on how you can ensure that your documentation is in fact legally sound. So for one, of course, there has to be client identifiers on each page of the nursing note. So, the client's name and their record number, so that there's no question as to whom this charting is about. Your documentation must be legible so that others know what it says. If no one can actually read what you wrote, then it's not going to protect you very well. Every entry has to include the date, the time, the name, and the designation of who completed the charting. You want to make sure that you're avoiding the use of abbreviations, but if you are using abbreviations, you need to make sure that they're approved by your facility. So oftentimes facilities might have a list of approved abbreviations that they're using. Only document your own actions, and we're never documenting for someone else or having somebody else document for us. This is a big one here that we sadly have to say. Avoid writing any critical or personal comments about the client, your coworkers, or the facility. Unfortunately, we have been seeing this happen, and those types of comments have absolutely no place in the nurse's notes. You cannot degrade your coworkers in the nursing notes. If you observe any wrongdoing or unprofessional behavior by your coworkers, you need to follow your duty to report and your accountabilities, but you don't document that in the nurse's notes. When you are collaborating or consulting with another healthcare professional, it's really important that you chart the reason for the collaboration and the name and the designation of whom you're collaborating with and what the outcome of that collaboration was. So as I said earlier, somewhere along the lines, we thought that we should not be including other people's names in the charts, but that's false. So if you just use that old RN made aware sprinkle and you're asked 10 or more years later, well, who was the RN that you made aware? Chances are you're likely going to forget if it's been several years after the fact. And then, of course, we are never pre-charting our actions, and that includes our flow sheet. So if you're someone who's just, checking something off the flow sheet, that means that it has been done. So I know that many of us, including myself, when I worked in the hospital, I've definitely seen nursing professionals grab those flow sheets at the beginning of the shift, and they just go check, 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 check all the way down before they've even started anything. That is not legally sound documentation. You only chart after the care has been given. So now I know some of you are also probably thinking like the reality check. Okay, Kathy, well, that's all well and good in a perfect world, where we're always fully staffed and I had the luxury of charting the minute after I've given that care. But what am I supposed to do when there's been 3 sick calls, the floor's crazy, and I barely have time to go to the bathroom? So I definitely know that that is your reality, probably most days, sadly, right now. But this is where you do need to really be coming together as a team and talking about how are you going to best meet your client needs and your professional standards together. That's where that intraprofessional collaboration really becomes key. So you want to be engaging your directors of nursing and your nurse managers in that conversation as well. So a couple of factors to consider regarding your charting and, how often should I be charting and how much should I be charting? So the first step, of course, is going to be for you to base it on your facility and employer policies and procedures. So this is where you should be having that open conversation with your nurse managers if you're unsure, so that everyone can be on the same page. Then you want to consider the complexity of the client's health problem. So have they recently had a fall? Have they recently returned from the hospital because of some sort of an event? Have they recently been ill? What is their diagnosis? What kind of treatments are they receiving? Because those factors are going to greatly impact how often you're going to be charting on them. You want to consider the degree to which the client's condition is going to put them at risk. So if they have had a fall and it resulted in a skin tear, obviously we want to be documenting any, dressing changes that we've done, assessments we've done on the wound, how is the wound healing, are there any signs of infection, things like that. And we also want to consider the degree of risk involved in the treatment of care. So if they had a fall, what was done as the result of that fall? If you don't even charge that it happened or what you did as a result, and then a family member or another staff member comes along and sees unexplained bruising on a resident, that's going to raise some red flags for people. So we always want to be looking at accuracy, and the courts have stressed the importance of documenting at the time of the event or as close to the event as prudently possible. If there's been a significant delay between an event and the documentation of that event, it might result in the courts refusing to admit the chart as proof of truth, which questions the credibility of you as a witness. So when you hopefully do have a discussion about that as a team, one thing to keep in mind is that third-party charting is not going to be a solution. So no one other than the person who provided the care should be charting the care. So it must be the person who's had that firsthand knowledge and interaction with the client, because if someone is charting for you, it might not be 100% accurate, which is going to cause you more problems later on down the road. The only exception to this, of course, is during those emergency response situations like a code in the ER when somebody may be designated as the charter because things are happening so quickly. So I do want to share with you now 2 real-life examples that speaks directly to the importance of considering these factors I just talked about and how much charting is required. So these examples I'm going to share with you, they really speak directly to the importance of considering how often and how much you should be documenting, as well as why your documentation is such a crucial aspect of your practice. So the first example is from our neighboring province in Nova Scotia, and the basis of this case is that the nursing notes completely contradicted what happened on the video surveillance tape. So the charge involved both an RN and an LPN, and they were charged separately for falsifying charting notes and forgery. The charge stemmed from the death of a 79-year-old male client that occurred in February of 2018. The man's remains were found on a walking bridge in the rear parking lot of the hospital, and the cause of death was determined to be hypothermia. The man was a patient on a secure unit of the hospital for 3 months, and most patients on this floor were there. They were either recovering from a stroke or they had some form of dementia. And this client was awaiting transfer to a long-term care facility. The video surveillance showed the client leaving the unit at 12:35 a.m. through an emergency exit and then leaving the hospital and walking into the parking lot. However, the nursing notes indicated that the client was in bed with eyes closed at 12:45 a.m. So that's 10 minutes after he left the building, as evidenced by the video surveillance. They also charted at 1:15 a.m. and 3:15 a.m. that the client was again in bed with eyes closed and testified under oath that they last entered the room at 2 a.m. The remains of the client were found at 4 a.m. by 2 other nurses who had gone outside for a break, and another notation was made at 4:05 a.m. that the client was not in bed. So as a result, both the RN and LPN were fired and charged with forgery. So a couple of things to note about this case that you might be wondering is, how did he leave the unit if it was a secured and locked unit? Normally, there's codes and alarms for that. So it was noted that in order to leave this unit, it required someone at the nursing station to enter a code to open the door, and evidence was entered into the trial that showed that the alarms were not working that night. So that was an issue. Also, when the remains were discovered, he was rushed to the emergency department where he was pronounced deceased, and testimony stated that a sense of panic ensued amongst the staff of that unit, and the nurse in question took charge despite not being the designated charge nurse that night. The nurse went to the emergency department to identify the client and returned to the unit to complete the charting notes, which creates further doubt that the 1:15 a.m., 3:15 a.m., and 4:05 a.m. entries were timely entries, because what it looked like is that they may have been late entries as a result of what had happened. There was also some discussion as to the possibility that a different client wandered into the room and laid in that client's bed. But again, that's hearsay. And as I said, the courts are going to rely on your documentation in the court of law. And since the notes told a complete opposite story than the video surveillance, it was really hard to prove that the notes were not falsified. So my second and last example for you is about a lawsuit that was launched against a nursing home as the direct result of inadequate nursing notes. So this case involved a 71-year-old client of a long-term care home who's had a significant medical history of malnutrition, pneumonia, frequent UTIs, and was a brittle diabetic. She also had a history of cognitive deficits, and she often refused her treatments and medications. So one morning at 1 a.m., the client was noticed as having shortness of breath, and her O2 sats were at 80% on room air, according to the chart. The nurse put the client on 2 liters of oxygen, and nothing else was noted in the chart at that time. At 2 a.m., the nurse documented that the client was coherent, but no other vital signs or O2 sats were documented. The client was asked if she wanted to go to the hospital, but the client declined. And there was no calls made to the family or the physician. At 3 a.m., her O2 sats went down to 70%. The nurse then put her on 3 liters, which brought it up to 72. The nurse still did not document that a physician or a family member was contacted. At 4 a.m., her O2 sats went down to 62%, and the nurse asked the client if she wanted to go to the hospital. It was documented that the client shook her head no, and the nurse still stated that the client was coherent and could make her own decisions. With her O2 sats that low, that's a little bit questionable. But again, there was no charting done to contact the physician or the family. At 6:30 a.m., she was to have her blood sugar checked. This was a scheduled blood sugar, but the MAR showed that this was not done, and there was no reason provided for this not to be done. And then finally at 7:15 a.m., one of the client's daughters was finally notified of the change in health status. The client was found to be unresponsive, and at 7:30 a.m., the physician was finally notified. The physician phoned back an hour later, so that brought us to 8:30, but yet nothing was charted as to what was discussed during that phone call. At 9:15 a.m., the physician came to the facility and gave a verbal order to transport her to the emergency department. She was transferred and died 7 days later. So as a result, the family sued the facility for medical malpractice, elder abuse, and wrongful death with allegations of inaccurate record keeping, failing to document and report changes in the client's condition. So when the courts looked at the documentation, they were deemed practically illegible. So that's another reminder to make sure people can actually read what you're writing, and that they failed to adequately describe a serious desaturation event, and that at no time did the nurse call the physician for direction. So this not only became a documentation issue, but it further showed that the nurse failed to meet the standards of care of a prudent nurse in accordance with legislation. So those are some pretty grim and sad examples that I just shared with you, but I think it does really show the importance of understanding how necessary our documentation is. And as I start to end this presentation, these are just a few things for you to consider in regards to your charting and your risk management, because hopefully you do have a clear understanding that effective charting is so important to client care, as well as for preventing and defending any potential legal proceedings. So we need to be aware of any of our workplace policies, guidelines, and procedures that your place of employment has regarding documentation. You want to make sure that you're aware of any guidance documents related to charting, like the regulatory documents that I talked about, and review what your standards of practice have to say about this. We want to be timely in our documentation, of course, so doing our best to chart at the time of care or as soon as possible afterwards. And we, of course, want to ensure that we're documenting often, carefully, thoroughly, legibly, and accurately, especially during those transitional periods of care, like a shift change or during, critical periods of patient care. So, something, following an event that's happened with your client. So as we're ending here, I wanted to throw up some of our more popular FAQs that we've been asked. And as I said, we do have an FAQ document on our website that we welcome you all to view as well. So the first question that we get a lot of is, do late entries hold the same weight in court as multiple small timely entries? So this is one of those, well, it depends answers. So according to the Canadian Nurses Protective Society, this can only be determined once it's actually been submitted as evidence. And at that time, the court is going to review the frequency of your entries and how soon you documented care after it was provided, with the assumption that the closer you documented to the care provided, the more likely it is that the documentation is accurate. So late entries are certainly permissible, providing that they are identified as a late entry. And entries made a day after an event is preferable to memories, years later. So better late than never, I guess. So that means that your late entries might not be given the same weight as notes made immediately after an event has occurred. However, if they're identified as such, they can still be relied upon at trial. So again, your documentation matters. Another frequent question we get is, are entries made at the end of a busy shift considered a late entry? So this answer is really dependent on what practice setting you're in and the acuity of the clients that you care for. So generally, the greater the acuity and complexity of your clients and your practice environment, the more frequent you're expected to chart. So if you work in the emergency department or ICU or labor and delivery, you are expected to chart quite frequently because things are changing very frequently. Whereas if you're in long-term care where the clients are generally more stable and predictable, you wouldn't be charting minute by minute, so much less frequently. So there was a case where an ICU nurse had jotted down notes on a scrap piece of paper while things were happening. And then she went back to the chart these things while just kind of approximating the times, and she did her best to reconstruct what had been happening. The courts didn't fault her for putting emergency client care ahead of her documentation, but they did find that approximating the times resulted in inaccurate charting and impacted expert opinion. So my next question I'm going to launch to you as a poll. So just let you answer that. And of course, it's anonymous. So it's just, can LPNs document on the care plan, yes or no? Give you a little bit more time to answer. I see everybody's still putting in their answer. Almost have everybody. A couple more seconds. All right, so I will share the results with you here. So most of you got it right. So 85% said yes and 15% said no. So those who have said yes, you're absolutely correct. LPNs are involved in all aspects of the development of the care plan in collaboration with the RN. So therefore, LPNs document their own assessments to develop and modify the care plan within their own level of confidence. So just like we always say, you only chart what you do, it is the same for the care plan. And sometimes that's confusing for people. And I think there's been changes in some workplaces with this one where it was kind of a false belief that LPNs had no business charting on the care plan. But you're doing it in collaboration with the RN. You wouldn't chart something in the care plan and not communicate that with the RN because the initial care plan has to be done in collaboration with the RN, but you absolutely can chart your own assessments and things on the care plan. And my last little FAQ to you, which I'm also going to launch as a poll. It's your last poll for today. Well, maybe I will. Maybe I didn't put it in there. My apologies. Never mind, I'm not going to launch it to a poll. If I did not sign for a medication, is it a documentation error or a medication error? So I get this one a lot. It is both. So failing to sign for a medication, it's not only a documentation error, so a lot of people like to say that, but it is considered a medication error as well. That is outlined in our standards of practice. So not signing for a medication is both a documentation error and a medication error. So thank you everybody for joining me. These are just some of the references that I used to put this presentation together. I'm happy to take some questions. I see there's a few chats there in the Q&A box, so I'll just have a quick look at those. I'll hang around for a few minutes. If you're not sticking around for the Q&A, thank you for joining. You can just leave the meeting at any time. You have the option to send your questions anonymously. There's a little tick box there that says send anonymously if you don't want your name shown. So I'll just wait a few moments to see if anybody has a question.